Our sixth Business Matters chat. As we have done in the past, we welcome your participation with questions following our speaker's remarks today. If you have questions, we ask that you please put them in the chat box and send them to Anna, and we will try to get to as many of them as we can as time allows. So today, I am pleased to have with us two respected healthcare professionals. The first is Kristin McManmon, Regional President of Ascension, Wisconsin, South Milwaukee, Racine Market, including All Saints, Franklin, and St. Francis hospitals. Kristin has served as Ascension, Wisconsin for the past 3 years, coming here from Columbus, Ohio, where she was President, Ambulatory Care at Ohio Health, a faith-based health system. While she hails from St. Louis, Missouri, Wisconsin is home to her, having lived in Madison and Baraboo for over 10 years, working for SSM Healthcare as Executive Vice President and Chief Operating Officer. Kristin's journey in healthcare began in a long-term care as a practicing social worker. She supports community efforts, including serving as a board member for both the Racine County Workforce Development and Racine County United Way. In her over 30-year career, she has been a fellow status member of the American College of Healthcare Executives, serving on committees and the Healthcare Executive Journal editorial board. Kristin received her Bachelor's of Science from the University of Dayton and her Master's in Healthcare Administration from St. Louis University. She currently resides in Mount Pleasant with her 3 children and her 3 dogs. Also with us today is Dr. Janice Litza. Dr. Litza is a Puerto Rican American and was born and raised in Milwaukee. She started her professional education at UW-Milwaukee and completed her medical doctor degree at UW-Madison School of Medicine and Public Health in 1998. She is board certified in family medicine and has completed additional fellowship training in integrative medicine through the University of Arizona in 2017. This allows her to bring a unique perspective to her patients' healing with attention to the whole person, their body, mind, and spirit. She has been in various academic and leadership positions, including residency program director at Northwestern University in Illinois and chief medical officer for a federally qualified health center in Milwaukee. She has committed her medical practice and leadership advocacy to serve all patients with special focus on vulnerable populations. She practices limited patient care at the Wisconsin Avenue Family Medical Center in Racine. She also serves as Regional Primary Care Director for Racine and is currently the Vice President of Medical Affairs for All Saints. In her free time, she enjoys relaxing in her yard, hiking, reading, cooking, and snuggling with her 3 rescue dogs, and spending time with her family and friends. The Racine community has been her home for 5 years, and Dr. Litza serves on 3 local boards. So please join me in welcoming these 2 ladies with us today. Kristin, I'll turn it over to you.
All right. Thank you. And I'm staring at this, realizing that I should have Janice Litza's name should be on this screen as well. Thank you for the warm welcome and the introduction, Matt, and to the RAMAC team. And for those of you who've had interest in having a chat about Ascension or healthcare or perhaps a recent pandemic we've been working our way through. Those tend to be vaccines and pandemic have been the questions that have been asked of Dr. Litza and I for the past many months, nearly approaching a year. I thought I might open it up. I didn't know if there were a few questions out of the gate, Matt, that I just want to make sure that we kind of include, just have a few slides at least about kind of current state and where we are. I don't know if you received anything in advance.
Well, one of the biggest questions that I'm getting here at RAMAC really has to do, and I'll just read the question kind of in a nutshell here. As the state continues to expand vaccine eligibility to more populations, which may include essential worker populations like manufacturers, food and agricultural workers, transit workers, et cetera, does Ascension anticipate coordinating with employers for vaccination options for their eligible employees?
Okay, we will definitely get into that conversation for sure. I'll just, I don't intend to be terribly formal, but just to provide it a little bit of framework and welcome questions. And if they, come up throughout this, these few slides, Dr. Litz and I are here to take those. But just, if you're not familiar with Ascension, as we continue, Ascension came into the Wisconsin market in 2016. So about March of 2016, where Ascension acquired 4 existing health ministries, kind of ranging from as far north as Eagle River and then as far south into Racine. And the intent and the goal was to continue to integrate and bring that together as one Ascension, and then fold it into our larger healthcare system, which is the largest not-for-profit Catholic health system in the country. And that doesn't mean that it's perfect. It means the largest, and there's always opportunities as we continue to evolve and refine and improve, that we're doing that every day. So coming into this and having been from outside of Ascension, and having had the opportunity to work in multi-state health systems and systems that had moved a little bit further along with integration, you can you have a good sense of what the end state, at least the future state, needs to look like. And bringing together 4 ministries, 4 different cultures that were all at kind of different states, and even within those ministries, different organization. It's been a journey. So I joined the team about a year after those initial acquisitions, and part of the system that was formerly the Legacy Wheaton. And I do see my colleague, Dr. Ross, on here, who was actively part of the leadership in Legacy Wheaton, as well as the leadership in the transition within Ascension. So our work has been about making improvements across all of our key pillars in our culture, and our patient family experience, our clinical quality, and our safety, our affordability, and how we deliver on that, and how we improve access across our markets. And so in line with that, it's also bringing the organization into the fold of the Ascension ministry, which has a long history rooted in a Catholic tradition, and kind of we stand on the shoulders of the sisters from multiple religious communities that served before us. And how do we bring our Ascension family together under those values and those principles? So, kind of flash forward, we have been doing that work. We've been aligning around regions and markets, making investments, bringing the organization together. But really, the conversation since March 12th of 2020 has been our response in the pandemic. So Ascension All Saints and Francis and Franklin worked in lockstep with our Ascension Wisconsin colleagues across the state, as well as our national colleagues, to establish our incident command structures. So those went into place around the 11th and 12th of March of last year. And that structure really kind of gave us a clear line of sight for decision-making and rapid decision-making and evaluation of data and information, as well as deployment and aligning our resources, our medical resources, our clinical resources, our support resources, to what we believed respond to the immediate surge. So I'd say our first order of business was, establishing all of the logistics, which were enormous. We still do to this day, kind of have daily reports that push out all of how many gloves we have, how many days hand-on gloves we have, our gowns, our shields, our masks, our N95 masks, any necessary equipment that's required to care for people that have been diagnosed with COVID, and our overall capacity, ICU capacity, intermediate level care capacity. So that those systems and processes, as well as how we were screening our associates and our providers, as well as At that time, we were still having visitors, how we were screening people coming into the organization, how we were testing anybody coming into the organization, all got established really early on. And just like every health system in the country, started to refine as the CDC guidelines were changing or improving or being revised. We identified our surge locations. Speak specifically to Racine for a moment. As an example, we have in the house about 330 beds. We run a census of about 200 patients at any given point in time. And how were we going to prepare to double that? And where were people going to be? So we identified all of our surge locations and our surge practices and at what we were going to need for each of those tiers to be able to accommodate that potential level of patient population, as well as being able to segregate as much as possible, particularly early on when we still were learning about COVID, how we were going to be able to separate patient populations. We track all of our equipment. The value of being part of a multi-state large system we've been able to bring equipment from Oklahoma when they were not needing, ventilators, or if they were not needing BiPAP equipment. We had staff join us from other parts of the country. And when we saw dips in our activity, our respiratory therapists, our ICU nurses went to answer the call in Florida and Texas and other parts that were surging at different times. We have our own supply chain. So we have a national supply chain that feeds us PPE and medications. And I can tell you with confidence while we monitored all of that, at no point were we in a position that we were out of something or didn't have a pipeline of supply coming in to our organization. And then clinical staff. So we had not only the staff, but also training and preparing them kind of in the moment for some of the changing practices and guidelines. So the practices and guidance was not only coming from the CDC, but from professional associations that support critical care, the provision of critical care or the provision of emergency medicine nationally. But then also nationally within Ascension, we had our national experts in infection prevention, in surgery, in emergency medicine, and so on, that were evaluating those practices and cleaning it up so that we could rapidly deploy the work through our trainers and educators into our clinical work right at the bedside. Within Ascension, we had really the national surge obviously hit in New York first. We saw that happen on all of our news channels at home. We have Ascension hospitals in New York. We have Ascension hospitals in Michigan. We have Ascension hospitals in Illinois, all who initially surged before we did. And Dr. Litza and I sat on calls with their medical leaders, their clinical leaders, and their operational leaders to understand what worked and what didn't, and some of the early practices in the treatment of and management improvement of a COVID population. So there was early guidance as well as ongoing adoption. So that has been, I've joked around, we have been like meerkats that are looking out over the prairie, warning each other of all the incoming activity. But the value has been that we've had kind of, I keep saying, a clear line of sight in terms of the clinical information as well as the supplies and resources required to respond. And then we couldn't have done it without our associates and our providers. I can tell you to the person, they have been unbelievable. Their commitment, they have the same family obligations that all of us do as we worry about, getting to the grocery store, making sure that we can teach our kids at home or offset, or balance some of the virtual learning. But these people have worked day in and day out, and they've worked in roles that they normally didn't work in, where we were training and deputizing people to support clinical roles like physical therapists that were then turning patients. While they're very capable of turning patients, we had to teach them and make sure they were prepared to work in some of the COVID designated spaces to do that. There's been innovation that comes out of this. And I was just reading a Harvard Business Review article about coming, in interviewing and looking at 600 companies across the country, what were the things that they're learning both in managing in a pandemic and coming out of a pandemic. And they distilled it into protecting your core and learning to pivot. And I think that I'm very proud that the team has worked hard to protect the core. And I talk about our core commitment to experience, to quality, to safety, to safe practices, while we were kind of balancing within what we consider pandemic or crisis practices, and also continuing to make sure we were positioned for the future. That doesn't stop the fact that we needed to, there were other services that we were in the midst of opening, and so that they were available to our community long term. There were providers that continued to recruit into the organization. But then there's also innovation that about recognizing that this is with us. The thing about some businesses that might be anticipating that they kind of get back to business or back to a normal operation, maybe they used to manufacture perfume and now they're manufacturing hand sanitizer. I don't anticipate that we are going to be back to business. I think that there are real changes that have occurred with those that we serve within our community and the way that we respond and take care of viruses, for example, that are going to be changed forever. But some of the innovations, out of the gate, we were among the first in the state to open drive-through testing. We opened our drive-through testing in Mount Pleasant by the end of March. We opened 20 sites across the state. We actually a little more than a dozen. We had 13 respiratory sites that were just dedicated to managing people that were suspected of having COVID or confirmed cases, so that you can keep them out of the hospital. We don't want everyone having to come to the emergency department. We can keep people safe and at home and get the care that they need. We have at-home monitoring in place. And then, of course, I think everybody saw the rapid development of telehealth. Some was in place, some wasn't in place, and that really grew. What I thought was really important, some of you heard me say this before, is that our addiction medicine and behavioral health providers really grew in this arena, which those disease processes, like many others, don't go away and continue to be able to respond and find a different way to provide the care. And then we've been the first Wisconsin health system to launch a multidisciplinary team that's really focused on what's affectionately referred to as long haulers. And those are having the chronic conditions and lingering conditions and symptoms from COVID. So then we move into our shot of hope. And so part of the story we always talk about is our sisters, whether they were part of, the Sisters of Mercy, whether they were the Sisters of St. Joseph Carondelet, the Franciscan Sisters, Sisters Sorrowful Mother, go on and on and on. Multiple sisters have been part of the fabric of our organization and part of the fabric of Catholic healthcare in this country. They responded to the call over 100 years ago. And when we had the Spanish flu. And if you read about that, there's so many things that are similar, right? Businesses were up in arms about being shut down. Masking came into question. They did mask their animals, though. There was masking of cats and dogs, of a belief system that there was spread that way. There were signs that we don't see today that we do see in those old pictures about spitting, that, because again, there was a lot of tobacco use and so a few differences, but some of the same, both politically, the business response, but from a healthcare community, the sisters really were leaders in going to where they needed to be. And they made a call to the other sisters and sisters who were traditional teachers, like the Sisters of Notre Dame. Thousands of sisters responded and ended up being at bedside and they were scared to death. They had never been around death. They had never been around illness. And the sisters that worked in healthcare did their best to train them and prepare them. And what I've said to our teams is that the difference is that in the summer, after 18 months of following the pandemic of 1918. In the summer of 1919, it fizzled out. And it fizzled out because enough people got it and there became some herd immunity, or people died. That's how it ended. We get to end with the St. Monica Senior Living Facility sign that says we are grateful for our shot of hope. And so we have hope, and we have this incredible scientific community worldwide that has been tireless in their effort to bring a vaccine to our community. And we want to make sure, as Ascension, to answer this question, that, that we don't always know what our role is definitively, but we want to be part of it. It is in our interest and in part of our mission to make sure that we improve the health of those we serve. And we believe that our role is part of the vaccine rollout. So we've provided more than 21,000 as of January 19th. We provided 21,000 vaccines to frontline workers here in Wisconsin. We've had 200 non-Ascension affiliated organizations. So I've received calls, Dr. Litz has received calls, my colleagues have, from people who are maybe not affiliated with Ascension and providers who aren't on staff at Ascension, but we responded to that and made sure that they were getting access to the vaccine. We've been involved in immunizing more than 175 dental offices, EMS divisions. We've opened up our doors, firefighters. We've opened up our doors, and it's a complicated process. I will tell you, I've never led through a pandemic. I see my friend Jenny Nelson on this call. We were there for H1N1, Ebola. Pales in comparison to what we've had to respond to here. The other thing I've never had the opportunity to do is to lead a mass vaccination effort. So clearly a fish out of water. But it is a complicated process of making sure we have the right information, the right timing, the right kind of separation that we didn't have to have during the H1N1 vaccine distribution that we need to have during the COVID distribution. So we're learning as we go. We appreciate people's patience. I know it hasn't been easy, and we welcome recommendations and suggestions. We're even finding that internally, we share a lot of information. We'll be moving to doing some more even internal education about the value of the vaccine. At this point in time, it's a choice for our associates and providers. It's not mandated because of the state of the vaccine right now. But so with that, it even comes with our own associates, making sure we're providing the education, the support to make the right decision that works for them. So while we have, the question is, do we anticipate, I'll call it the 1B rollout? We're definitely impacting some of what I'll call 1B today. Today is Wednesday, so Monday was in a meeting with our county and city teams and with our vaccination physician and administrative leaders to talk through how can we coordinate, where are the right places so that we can at least start getting out to the first group that we anticipate the release, which is the 65 and older. In Racine County, I think the number is close to 25,000 that are 65 and older. You can take your guesses on how many will be open and willing and interested in having a vaccine. If we said it was 50%, so where and how will be the process to get to, 12,500 65 and older population, keep them socially distanced, make sure that we actually have the right information, the information that we need to get them vaccinated in the first place. And then to also make the arrangements for the second dose of vaccine within 21 days. And then of course, there's the storage and the chain of custody on the vaccine itself. So we intend to play a role in this. We intend to be supportive. We intend to be a partner. I think there's a lot of details that still have to be worked out. And then of course, the clarity on kind of who's next in the process. But our commitment has been to play whatever role we can to make sure that we are immunizing our population. So, as said, listening to kind of taking to heart the feedback out of Harvard Business Review and what organizations are saying they're considering, and I know many of you are as well, is, to protect the core and to continue to pivot, to move forward. So in protecting the core, we've had 30 providers join the team in Racine over the past 18 months. These are numbers that Dr. Ross and Dr. Litza and I have always addressed and answered over time. There were, with the transition in 2016, providers left the market, left the community, left Ascension. And I'm not going to make excuses for why or reasons why. We understand to the individual why they make decisions. I think all of us have been in part of a business or organization at a time of change, and it doesn't surprise me. I mean, people have to make choices for what's right for themselves and their families first, and I want them to do that. So that's, I think, part of the normal transition. If we look at any departures that happened in that kind of 2016 window, and we look at today, we're a much different organization. We're probably a net gain of probably 50 to 60 providers over that number of where we were. So it's a net improvement. If I look at how this organization has changed from maybe the past 7 years, it's probably, the numbers are pretty incredible about in terms of just the growth of the provider base and the physician base. We continue to evolve and have partnerships, and these are important for our business community. Coming out of the Madison market where we had provider-owned health plans, our business was making sure that we were delivering on cost and affordability to our employer partners. And we did that by offering an affordable health plan and partnering on making sure that we had ambulatory and retail-facing pricing. The Kenosha Digestive Health Center, which we opened in June of 2020 on the retail corridor in Kenosha, I can personally attest to the wonderful experience there, is ambulatory pricing. The Racine Digestive Health Center opened at our first patients on January 4th, 2021, ambulatory pricing. So we are slowly weaning ourselves off of hospital-based billing and hospital-based pricing because we hear what you're saying to us. We started our imaging services at ambulatory pricing at Highway 20 in our Mount Pleasant Ascension site. And then we're working on opening some additional urgent care locations, again, in consideration of what we call, ambulatory pricing versus hospital-based pricing. Our ambulatory surgery center at Mount Pleasant is also, again, an example of ambulatory versus hospital-based pricing as we move into this. And then Ascension Wisconsin Employer Solutions is now providing health services the city of Racine employees. So these are just some examples of kind of what I say, protecting the core and continuing to move forward with, what we've committed ourselves to do in this community. So that is the end of the talking head. I'm going to stop sharing and just open it up for questions, and we'll direct all of those to Dr. Litza.
One quick one to start us off. It might be a little basic, but can you get the flu vaccine at the same time as the COVID-19 vaccine? Like literally shot in the arm same day? Is that recommended or not?
Yep. So currently they don't recommend giving other vaccines because it's still under the emergency authorization. So we're closely monitoring any side effects or potential. So any variable that might complicate that is not recommended. So it's within 2 weeks, I think. I could be wrong, I could be making that up, but it's not a long distance between the two, but it's not recommended to give any of them together currently. I think that will change. So there's a lot of vaccines out in development. If you kind of Google them, I watched this, the New York Times has like a vaccine watch. So all across the world, what's being developed. And so there's one or two in development that is the flu and the COVID-19 together that may have the best potential for the future, but just not right now.
So I guess let's go back to the first kind of question that I put out there with regards to manufacturers, food, agriculture workers, transit workers. Is the hospital going to be coordinating with employers or on the vaccines, or is it really, hey, the vaccine's available, go out and get it, and you're on your own?
Yeah, I think where we are right now, Matt, is trying to determine what the workflow is going to be for this group 1B. And if the first release is the 65 and older population, then we have to kind of figure out how to distribute. I'm assuming that everyone is going to, if we know there's 25,000 people in Racine County that fall into that category, and if we assume half are going to say that they would like the vaccine, and if we assume about a fourth of those are going to get their vaccine through their provider, how are we making sure we get to the rest of those individuals? And that workflow and that process is going to help us define how we can do this going forward with employers, other groups in the community. We've learned already from distributing 21,000 vaccines about what works and what doesn't work. We've standardized that practice across all of our sites. Our Franklin Hospital was a statewide hub and distribution center for the state, just simply because of the freezer capacity that we have there. So we're learning things, and we're also learning that when we start moving into the public, there's a different set of information we have to have. We have to track information in electronic health record. We have to secure additional demographics on the individuals that we'd be vaccinating. So our intent is to continue to be part of vaccine distribution across the community. We just don't know, as this process is evolving, exactly how that is going to happen.
Okay. Another question that has come in also is, in each of the vials with doses, how many vaccinations can you get out of each? And at the end of a day, is there some that's left over? Is it able to be used the following day? Does it go to waste? If so, what's happening there?
Yeah, that's a great question. So we have the Pfizer vaccine. The Pfizer vaccine is 6 doses. When it was released, just to give you an idea of how quickly this information changes, when it was first distributed and we started receiving it, we realized that we could really get easily 6 doses. I'll say 6.5, but 6 doses. So we had to get the approval, and it has to be federally, signed off that you can move into the 6 doses. So we can get 6 doses out of that vial, and the first dose is as effective as the 6th dose. So there isn't a difference or a change that happens. And then let's just say that we have right now with our associates and our providers and those who we've already been releasing vaccine to, we might have, let's just say that we've distributed 200 and we still had a few doses remaining at the end of that vaccine shift. We will literally go out to the floors, we'll go out into the clinic, who didn't get their second dose, who still needs their second dose, we're pulling them in so that we're not wasting any vaccine. And we're watching those numbers throughout the day. So if somebody had an appointment to get their vaccine, but they ended up going to another site to get it, it's in the system, then we're actually releasing whole groups to make sure that there is nothing wasted at the end of the day.
Anna?
Yep, great information. So a little bit of a shift there. We know this is a federal rollout. This is not just Wisconsin, but we are hearing on the news and in reading that Wisconsin seems to be behind. Do you think we'll be able to catch up, or once we're kind of a little bit behind, are we are we always going to be behind? So, any insight as to maybe how we can quicken the pace, or why some states do seem to be ahead of Wisconsin?
I was going to kick it to Janice. Looks like she was going to kick it to me. It's a great question. And I've wondered, some of the things too. I know that I can speak to what we do within our own system is that we're sharing information and we watch where we are in Florida and Michigan and other states where our ministry is functioning, to see if there's comparisons or learnings and anything that we can do to more rapidly deploy the vaccine. I don't think that we have enough information at this point to just point to a typical, if you will, a typical declination rate, how many people are declining, because again, it's still dependent on how many were in the initial release pool and are we comparing apples to apples, but open to any feedback or suggestions, and as mentioned, continuing to try to find if there's better ways to do this.
Yeah, I don't have anything, earth-shattering to add other than, we have processes in place. So we were ready to start administering the vaccine a week before we actually got it. So we had a schedule and template and everything ready. And you're right, it just depends on the distribution. And we found out, so the process is wonky in that we found out, I think, a day ahead of time. So within 24 hours, we're getting the vaccine and we go from there. And so that's why we put a schedule together. So just to speak to the other question, what do we do with the vaccine? So everybody is scheduled to the best that we can, and we try and fill the schedule as long as we have available vaccine. But I've worked in our vaccine clinic, and so that last hour, we're counting how many doses, how many people are registered. We try to really match it up for the end, but we are trying to really make sure, we've opened it up to everybody who's possible, so nothing goes to waste.
And once we, so we still have, still moving through second doses with our own associates in those front line that are in group 1A. And so when we look at just the physical space requirements, so just to give you an idea, that we have to get some baseline information. We have to understand, like, have you ever had a reaction to a vaccine? Because that, impacts our ability, how much time we need to spend with you after you're vaccinated, any allergies, et cetera. And then we have to document all of the vaccine specific information. And so then obviously it's injected. And I think from a productivity perspective, I think we run 12 vaccines, per nurse per hour, per vaccinator per hour. It might be 14. And so then all of that has to also get entered into WER so that it's entered into the statewide registry for vaccines. So that includes like the lot number, which type, was it Pfizer, what was the type of the manufacturer, the lot number, the date, and then some additional specifics. All of that has to be entered. So there is this kind of like paperwork component that is time consuming, not to the person that's going through the process, but just to make sure that it's supporting the overall process. And then there's just 15 minutes of clinical observation and then 30 minutes of clinical observation if the person has any history of reaction. I think, Janice, from all the doses that we've done across the country, I mean, it's been a handful of any kind of reactions that were considered, more serious. But in case that there is a reaction, we still have to do that. So if we're offering vaccine clinic in our hospitals every other day, so that we can get a full 12-hour shift of coverage of trying to get to first and second doses for frontline staff, we're looking at those alternate days as being where we can start potentially opening up and providing additional coverage. The logistics is what I've just described to you. The things that are on my mind is, people coming in from the community And particularly if we start with our 65 plus or 75 plus, depending on how it's ultimately released, what support systems are in place? Are they having somebody with them? Are they needing to have somebody with them? How are we socially distancing those folks? How are we actually creating more recovery, more spread space for the observation? So it's just some of those logistics that we're working through, making sure that we have kind of a safe practice to bring people in from the outside, if it's physically at some of the hospital sites, or if it's at some of the local high schools or the other venues that could accommodate the size of the population that we're talking about that we need to vaccinate.
So,
I'm sorry, Matt.
no, go ahead.
So
Please, Council.
the type of vaccine is kind of determined by the state. So we have Pfizer, and that one needs the ultra freezing, and it's 21 days. So we at All Saints will only have the Pfizer. We won't have the Moderna. So the Moderna is the one that may be out in the community a little bit more because it doesn't require additional freezing. There's a 28-day window between there. So it might be a little bit easier. So they're both made, essentially they're mRNA. So they're very equivalent in the type of vaccine that they are. But just, that's one variable that we're limited by. They don't allow distribution sites for the vaccine to have both of them at the same time. So I just wanted to add that, just because there's always a lot of questions between the two vaccines, and we're a safer place, really to store and distribute the Pfizer vaccine. Other communities and other clinics won't be able to do it. So the Moderna is more likely.
So that goes into the question of maybe the elderly population. Someone gets their first vaccination shot here, and then they travel to another community to spend their winter or a month, whatever it is. How do they get a second shot? And if they got Pfizer here, could they get Moderna if that's where the other place is, or do they have to have Pfizer as a second shot?
Yeah, currently, whatever you start with, you have to get for the second shot. I know for our associates and physicians and employees, we basically said, if you're going to be here for the 21 days and you can get the 2 shots, if it's questionable where you're going to go, it might take a little coordination. I'm not sure how that's going to work if they travel in other places, but you get a little card. It'll say which one that you had, but you do have to stay true to either the Moderna or the Pfizer. The expectation is not to flip-flop between them, and probably more because it's experimental, but it's still in that experimental use. So they really want to keep the pure so they can track for any adverse events or side effects.
Recently, there's been some Zoom calls that I have participated on as they affect the business community. And that is whether employers can mandate their employees to get it. Should they mandate it? Can't they? It's not a right or wrong, but from the hospital's perspective, are there recommendations that you could make to employers to be proactive in the health of their employees and possibly getting the shot? Neither one of you wants to comment on that one.
I've had this question asked a lot. I remember the time, as do many of you, when the flu shot wasn't mandated for the same reasons, right? The newness and such. I think right now we're at this point of kind of myth busting a bit and trying to educate and do the best that we can with the information that we have at hand. So as a hospital, we're kind of in the same position that non-hospital organizations are in. And I think that there's so much information out there, but for every 20 vaccines we give, we believe we're saving one life. And so, whose life is that? And, I know there was a lot of rhetoric out there about whether or not this was real, it's not real. And I'm not going to opine on it. I can only just tell you that having been, and I see colleagues from other health systems, and they've been there too, this was very real. And it's And a lot of lives have been affected by this. People have lost their lives. People are in a position now where they're dealing with chronic illness. I have friends, you have friends that were young, healthy otherwise, and are now in a long-term state of uncertainty about what this has done to them. And I think that we're finding that we just have to have town halls and conversations and continuing to message what we do know, both about what we've been through as a country, as a health system, the past 10, 11 months, what we know about the disease and what we know about the vaccine, to try to get information. I personally, as his, Dr. Litza, to go out and say, okay, we've got a few doses left. At that point, you're just grabbing who you can, because, right, you don't want to waste. I've had people say, well, my doctor told me to get it, but I read online, or one of my friends Instagram me not to send a message out about not doing it. And I think it's trying to get as much facts in front of people so that they can make their own the best right decision they can, but we want to get the facts in front of them. I don't, Janice, you must be hearing things from your patients as well.
Oh yeah, and friends and family. So I would say, knowledge is probably the best tool. And I recently read a Time magazine article about kind of the history of the mRNA and the different vaccines. And I thought it was really great from it has science, but not heavy on the medicine. Everyone's afraid that, oh my gosh, we just developed a vaccine in 9 months. Well, the technology has been present for a long time, for years. I mean, genetics, we just had, we got the genetic code and we were able to plug it into something that already existed. And, the other thing that I have shared with some patients and some individuals, which you all may appreciate, is money. Somebody decided to pay a lot of money to push this technology forward. Elon Musk is an investor, Bill Gates is an investor. So, technology and the financial resources to really make it happen and push, because we all have a shared interest. So this technology has been used for cancer treatment. And so for some people, I said, well, would you take something like this if you had cancer, or your loved one had cancer? Probably more likely, otherwise. But I think that really just arming with knowledge and the safety. And if we really were mistrusting of this, we really would just have wiped out our entire healthcare system across the world, because we're the first ones. It's not just the United States. The science and technology has brought, really our international community together. And, that's one of those things that spoke loudly to me as well. So it took the medical people and then the technology people, and they came together to create this and push it forward. So, but I really liked, honestly, I don't have any disclosures. The Time magazine in December, I think it was in December, I thought was a really, really good article to just walk through and explain, some of the history.
That's a really good point. And I think some of the bureaucracy got out of the way a little bit too, to make it move faster. So one more vaccine related, and then I do have a non-vaccine related. So we have about 10 minutes. We try to keep to 45 minutes to an hour. So for those who are 65 years and older, how should they get on the list to make sure they can get vaccinated? And I think this is an important question then for anybody else for the next phase. So what should anybody who's 65 years and older be doing right now to get on the list? If there's a list.
Yeah, we don't currently have a magical list. We are sending out communication to our patients, saying, we're getting ready, you'll receive some communication, and this is how and when, because in order to manage the doses, we do need to have people registered. It's not a free for all, walk in, stand in line for hours sort of thing. The best approach is really to have it scheduled. And so once we get that up and running, similar to how we did for the physicians and the staff, once we get the process going, then we can start to open it up in other ways. But it will be by invitation. initially, and then, once we'll find opportunities to invite other systems, and that's all I know that we're doing. So I don't know what
That's for how we're reaching out to our patients. And then, so the list that we do have just is for people that are healthcare workers that are not affiliated with a hospital or a health system, EMS, first responders, dentists, the independent physicians that practice in the ambulatory community and don't need to go to the hospital, don't have privileges at the hospital. Those folks, as they've reached out to us, we've put them on a list and then pushed out by text and email their invitation. I want to call it invitation, their opportunity to schedule their vaccination. And so that is that list that's specific for that group 1A. Exactly what Janice said, we'll be reaching out to our patients as the distribution channels become a little clearer with this first group of 65 plus. And then this is part of the discussion also, with the county and the city, is then how do you get to the rest of everybody? If they're not, so again, if there's 25,000 in the county that are meeting that eligibility criteria, first, how do you even communicate to all of them that are not in a patient system already? And so I think those are some of the logistics we're trying to figure out.
That was a good clarification. So if you have a doctor at Ascension through the system, you will get an invite from them as opposed to us calling them and bogging them down. So we should wait for the communication to come to us, is what I heard. Okay, thank you. A non-vaccine related question that could be good to just kind of move off of the topic for a minute. How do you, I have to find it now. What are some of the biggest challenges for recruiting new physicians to this community specifically? You said you've had growth. What are some of those challenges?
This is a great question. I think I like to say I was a child when I started, because when I think about 30 years ago, but it wasn't the case. But I did a lot of physician recruitment a long time ago, and it was totally different than it is today. Generations are different, right? Everyone's different, and what's important to people. And there was a time when doctors we would recruit them, and you could kind of plan that this is where they were going to be for 30 years of their career, 40 years of their career, retire with your organization. And then there was kind of a whole period of time where there was rapid employment, and then a period of time where that softened. And I would say that we're kind of back to this place of where, with some of the federal discussions time and again around healthcare reform, I think it's very difficult for large groups to really kind of make sure that they're competing, particularly with the managed care plans and being able to sustain, though some have been quite successful in doing so. But we've seen more and more employment. We've also seen changes happen where a desire to have work-life balance. I think that is a time where doctors would start, and it was so important that they were getting out into the community, building relationships, making sure that they were getting to know area businesses, getting to know referral sources, and working closely to develop their own practices. I think what we're seeing now is much more movement into, I want to know when my day is going to end. I have a family, I have other personal commitments. And when we look at systems like Kaiser, who's been out in front of everybody on managing to value, or managing a health plan, or managing a population, they moved to a shift model many years ago. So, that way a doctor could take an entire day off and not just maybe start later in the morning, so that They could ensure kind of a work-life balance. They could make sure that their patients always had access to that particular specialty. And so I would say that we see a more, not entirely, but we see more transient nature to some of and portability where people have wanted to move because they've desired perhaps a different work-life balance or a different approach. So I just paint that landscape so you know that that's real and it's out there. In terms of recruiting to our community, I think the challenge is, I think the challenge is not specific to the community, is some of the specialties that are harder and harder to attract. Psychiatry as a profession does not have enough psychiatrists to serve the mental health needs that have emerged in our country. And so very challenging specialty to recruit. Ear, nose, and throat, ENT, otolaryngology. ENT is very difficult to recruit in that specialty. Some of that is because of the work-life balance. They don't want to have to take call at a hospital and respond to the middle of the night emergencies, but they would like to do sleep studies and outpatient surgery and outpatient care. And so how do you make sure that you still have those emergencies? Because everyone's right? You do have an expectation that if there is an emergency, that there's somebody able to respond. And so we have to kind of create more creative options to meet those needs and make sure that we can try to preserve that work-life balance. So I think that's real, and that's a challenge. It's more specialty specific. In terms of its specificity to the community, it always depends, right? It always depends on, Janice knows this about me when I see candidates coming in, and if they've grown up and spent their whole life on one of the coasts, I'm like, what? Okay, I need to understand really upfront, like what are they wanting out of the Midwest? What's important to them? Where's their family? Where's their connection? Where's their point of interface? And why do they want to come here? I find that when we have candidates that Wisconsin, Northern Illinois, Milwaukee, east side of Wisconsin is home to them, or they've got loved ones or family nearby, just like any of us, right? I mean, that becomes a factor in the decision. And so we have to understand that and make sure that that it's a good fit. Janice, do you have other comments about any either barriers or strengths?
Sure. When I interview candidates, a couple of things I look for. It depends on, most of them have younger families. So they're looking at what are the opportunities for their children, for enrichment, the schools, just normal activities. I always get asked about the diversity of the community and the population, so that, a lot of physicians come from diverse backgrounds. So in terms of food, cultural fit, shopping, comfort level, that is real. And if you're a physician in a community, that's important for your family to feel welcome. Convenience and technology. So, having a Lyft or an Uber, DoorDash, all those kind of things. When you're working, 12, 18 hours and you're tired and you're single, you don't have a family, you need all those conveniences. So I think, Racine has a rich culture. I think it has great diversity. There's always opportunity for growth. I don't have younger children at home, mine are adults, so I can't speak to what that world is like, but the medical nature, and this may be getting off topic a little bit, but being the primary hospital, actually there's a lot of opportunity to see different pathology that comes in, and that's actually exciting for a lot of physicians. So it's not the same thing all the time, they see something different. But those would be kind of my high level things. And I think we're doing well. If once we bring people into the community, it's an easier sell than most, I think, would think.
Well, and great brings great, right? So we spend a lot of time making sure that our candidates are involved with our physician leaders and are really clear out of the gate. We knew we had opportunities around patient safety, quality, some of our results, and have turned those around. And it's because of physician leadership. And we have a very strong patient safety and quality structure that is led by and supported by our medical staff. And those are the very doctors that are part of the process to hire for fit and to also communicate the kind of culture you're joining and what we're doing. And so I'm thinking about, we've got a candidate tomorrow. So, we were very thoughtful to make sure that, she would meet, other physician leaders and who are kind of part of the future and have been part of some of the improvements.
Great. Well, it is a couple minutes after 3. I want to thank both Dr. Litza and Kristin McManmon for being our guests today, taking time out of your very busy day to be with us. We truly appreciate it. So please know that your time with us today was well spent and well informing to the community. So we appreciate that. I want to thank everybody for submitting their questions along the way, and remind you that our next Business Matters chat is going to be Wednesday, February 17th. Our topic is going to revolve around education. We're currently working to secure our speaker for that day, so we'll watch for more to follow. So again, thank you to everyone who attended, and to our 2 guests. We appreciate your time. Thank you, and have a great day.
Thank you, Matt, Carly. Yeah.
Thanks. Thank you.